this is the second half cardiology from Ryan. After I was really exposed to this field back in sophomore year, I had an opportunity to shadow a lot of different specialties, and I stumbled upon interventional cardiology. It wasn't one of my main ones that I was interested at the time, but after shadowing this specific doctor and really seeing his day-to-day life, I was so mesmerized by the different kind of lifestyle that I've seen as compared to a primary care physician or a general practitioner. During my time here, I was able to observe many complex heart procedures. I was able to see kind of like the less aggressive approach to open heart surgeries, which is very minimally invasive procedures. And I was able to see how they can also save lives. And I gained insight into the very fast-paced, multidisciplinary, and collaborative environment of the cardiac cath lab. This mentorship not only deepened my interest in medicine, but also really solidified my interest in pursuing cardiology in the future, specifically interventional cardiology. And I'm really appreciative and really amazed by the dedication and precision that it requires. So, brief introduction. What is interventional cardiology? So, as we all know, cardiology is the study of the heart. If a resident wants to specialize further, say more invasively, you can go in one of two routes, diagnostic or interventional. I'm here to talk about the interventional part. And interventional cardiology usually specializes in the diagnosis and treatment of heart conditions using minimally invasive procedures. This has many decreased risks compared to very big aggressive open heart surgeries because there's less kind of making wounds in the body, which as a result has a shorter recovery time, less risk of complications, and overall just a shorter recovery time in general. So the surgery is usually conducted by sending a small catheter through the radial artery or the femoral artery, one of the two. And after sending this catheter to your heart, the doctor then sends all kinds of stents, balloons, and other devices on the catheter to address the problems of the heart. So this is the actual cardiac cath lab that I got to see. And the cardiac cath lab uses imaging guidance, specifically X-ray fluoroscopy, to see the heart in real time as the doctor's operating on it. So right here, you kind of see, it kind of looks like AC, this is called the C arm. And basically, from here at the bottom, there is something called the eye, and that's where the X-rays are shot up through here. And the patient's head's kind of around here. The head, chest is kind of where they're at. This eye sends up the radiation from here, and then up here at the top part of the C arm is where it captures the imaging, and then all that imaging is shown on this monitor. It's a really big monitor, and the doctor sends right here and they see that monitor in real time. And also, this is a cardiac catheter sheath kit. This is basically the first kind of device that the doctor uses to send the catheter and gain access to the artery in order to start the process. So you can't really see in this picture, but usually there is kind of a lead glass wall on the other side, and that's where I stay most of the time. I wasn't really allowed in this room specifically because you use a lot of radiation, and it's just not very healthy, and I didn't really have the equipment to protect myself. But the doctors and staff did. They wore really big, chunky lead aprons, and this helped minimize the amount of radiation exposure that they get, which they get on a very daily basis, almost regularly. And so the place that I was in was the control room. I sat there with a monitor nurse, and I was in front of a very big monitor. And whatever the doctor was seeing on the monitor, I saw in real time. So I saw them sending in contrast, putting in stents, putting in balloons. I saw everything just as they did. So first, now I'm going to talk about my mentor. I was matched up with Dr. Isaac Tafik. He is the chief of cardiology at Monmouth Medical Center, and he is an interventional cardiologist. His areas of expertise also include structural heart interventions, peripheral vascular interventions, and cardiac imaging. I also got the chance to round with his other colleagues, Dr. Anwar, Dr. Penchal, and Dr. Eisenberg. And these doctors have allowed me to observe their procedures, round with them, and also meet their patients, which I am very grateful for as well. And last but definitely not least, I have the cardiac cath lab team. So this makes up techs, nurses, anything and everything in between. I spent the most time with them actually, and they taught me almost everything that I've learned from this experience. And I was given kind of a play-by-play on the procedure as it was going on from them since the doctor was operating and I couldn't get into the room. And I learned so many different diseases, treatments, procedures, medications given to the patients, and more. And moreover, I was really accepted graciously into their team, and they really treated me like one of their own, and I did not feel awkward or like an outsider at all, which I really, really, really appreciated. So my mentorship took place here at Monmouth Medical Center in Long Range, New Jersey. Specifically, I was in the cardiac cath lab room, which is this. That's actually one of the techs there. So I'm going to now talk about my aha moments. They're mostly centered on patients who had somewhat different conditions and history that made them somewhat of a unique case when it came to traditional procedures. So I want to first talk about this spina bifida patient. So to start off first, spina bifida is a type of birth defect that happens in utero. It occurs when the spinal column doesn't properly close over in the early fetal development months. So as a result, when the baby is born, they often have a lot of developmental defects to the lower half of their body. That can include weakness or paralysis of the legs, which can involve using canes, walkers, and even wheelchairs. It can also have a loss of sensation or completely loss of bowel and bladder control. So with this patient, what happened was, so we knew that he had a history of spina bifida, and as the doctor was in the room and they were trying to get access from his radial artery, his arm kept spasming, so then they switched to the femoral artery. So when I mentioned that spina bifida affects the lower half of the body, it unfortunately also affected his femoral artery down there as well. So usually compared to the radial artery, the femoral artery is a lot bigger, has a greater width, and therefore a lot more blood flow. And because as a result, it's a lot easier to gain access to it, but doctors don't really try to go for that as a first option because it makes the recovery a bit harder. When the patient is in post-op, they cannot sit up. They have to be laying down for an extended amount of time, which is not the best. So that's why I try to avoid it, but the doctor had no choice in this case. But because the spina bifida, because the under half of this patient's body was so underdeveloped, the femoral artery was even thinner than the radial artery, which was kind of counterintuitive, but the doctor really struggled for a while to kind of gain access to the femoral artery. It took him like 3 or 4 attempts. By the end, it was done, but this kind of helped me realize that you really, really have to take into account the patient's history, their past medical conditions, any kind of defects that they might have with them, because you can't use a cut and paste textbook copy approach for every single patient. Every single patient's anatomy is different, their history is different, therefore going through that procedure is going to be different. So what the doctor did eventually, they used a kind of like a very stiff catheter in order to kind of force it through the femoral artery without nicking it, and that kind of helped them gain access. So this is kind of what the femoral artery looked like as a result, because they had spina bifida very underdeveloped. It was very, very, very thin. The patient had a standard left heart catheterization, coronary angiography, and possible PCI. PCI is a percutaneous coronary intervention, basically just very fancy lingo for saying they may or may not put in a stent based on what they see in the imaging. So, like I was saying earlier, they couldn't really use the radial artery because it was very blocked. They always do imaging during procedures, and they saw that this patient had a blocked distal right coronary artery. So that's what they wanted to address with this procedure, and that's why they put in the stent. And yeah. My second aha moment is they were talking about the leadless pacemaker. So this was kind of a brand new thing for this hospital, especially the kind that they were using. And it was a very big deal. I unfortunately did not get to see this. This happened before I arrived that day. But I was able to, I asked the nurses, the doctor about it all, and they told me everything. So I'm going to talk about that now. So this leadless pacemaker, the way it's different is, instead of being implanted on the fascia on top of the heart, it goes directly on the heart, right above the right ventricle, especially where the SA node is. And this pacemaker is very, very small, like kind of size of a pinky. It used to be a little bit bigger on the size of a matchbox, and because it was a bit bigger and a bit more bulky, whenever it's implanted into the skin, it's very visible. You can see it from the outside. It's kind of hard and bulky to work around with. But this, as a result, on the other side, because it was so small, so tiny, and because it was implanted much deeper into the skin, it felt like there was nothing there, and it was still giving the same effects and even better effects than a normal traditional pacemaker. So I was really, really fascinated by this kind of constant advancement in medicine. I know we hear about it all the time. It's one thing to hear about it, but then seeing it right in front of you is something entirely different. I was so amazed by how fast medicine is progressing in this way. And for this procedure, because it was such a big deal, there was a lot of team coordination involved. I had cardiology, anesthesia, and nurses from a wide variety of specialties all helping out with this. So that's the pacemaker right there, and then the one next to it, that kind of like small little hook like thing right below it, that's the part of the catheter that we use to put it into the body. And then right next to it, you have like a bunch of trial pacemakers as well, if this one didn't really work out. So in this picture right here, you have the catheter that the pacemaker was put on in order to put it inside the body, and this is the pacemaker itself. And then this one right here, you see, this is the pacemaker after it's implanted in the body successfully. So I thought that was really cool. And last but not least, from my last aha moment, I want to talk about something that is a bit unusual. Interventional approaches to anything is generally seen as more, like less risky, more beneficial, but in this case, it was the opposite. So we had this patient who had a procedure called Impella at RWJ, and what happened was she got this procedure done, and there was some kind of complication during surgery, and as a result, she had to have her leg amputated. So it was a complication of the right femoral artery specifically, and she had to do a lot of stenting as a result because now there was a huge part of her body missing, and the body was kind of like recovering from the shock of it. She had multiple stenting procedures done in multiple arteries of her heart. She had like 5 or 6 stents on, which is way above the normal. Usually it's anywhere from like 1, 2, or 3. She had 5 stents done because she wanted to avoid the very big, scary risk of having open heart surgery. But as we'll see later on, that might have been the better option for her. So even before this Impella surgery, she was already in like really poor health. She had peripheral vascular disease, so already her veins were very diseased, very tiny, very narrow. So with all this extra strain on her heart because of the stents, it made her health and her overall general condition way, way worse. And I asked the doctor later, if interventional cardiology is so minimally invasive and overall beneficial, why was it detriment to her in her case? So what the doctor said is it was probably better for her to have an open heart surgery with 3 or 5 bypass grafts as opposed to 5 or 6 stents, is that the stents can actually close easily as opposed to just a bypass graft that can be effective 10, 15 years, maybe even a lifetime, depending on how like the patient's like overall like general condition. And the main issue is in your heart, you have your coronary arteries. There's 3 main ones. You have your LAD, left anterior descending artery, your right coronary artery, and your circumflex. So the way that the stents place, if the stents place, okay, so I have the top one up there is a normal right coronary artery, and the one down here is a left coronary artery. It's kind of hard to tell, but you see all these arteries going. You see this one right here. It stops very, very abruptly. That's where you know there's a total occlusion here, and the blood flow can't continue any further down. And that was actually because the stent that was placed in before, one of her many, many stents, it was placed in a way where it actually blocked off flow from another branch coming off of this. And while it might have, I think the stent was placed somewhere up here, while it might have saved the flow from this artery, it in return stopped the flow of this one. So if we have a block of a coronary artery, it will lead to death of heart tissue in that area. So it's okay generally if you're kind of saving if you're saving one giant branch and like sacrificing a smaller branch. But in this case, it did a lot more harm to her than good. And now, if they were even to do an open heart surgery, they can't anymore because the heart is so negatively impacted. It's really, really, really hard to sense because it's usually considered permanent. all those scans and all those contrasts, all this imaging, it just made sense to me in a way. And I was taught about a lot of different procedures like angioplasties, the PCI I mentioned earlier, LHC, RHC, different catheterizations. And I also really enjoyed seeing it wasn't just the doctor involved, there was all these nurses, all these techs, everyone involved was there. When the doctor was operating at the table, there's always some kind of nurse who was basically dressed up like the same kind of PPE as him, and he was always, whoever that nurse was, he was always helping the doctor almost like very closely, like even doing part of it themselves. So it's not like the doctor was like an elevated position and everyone around him was just like helping. They were all working together like colleagues, not as superior in any way like that. I really learned I learned the importance of proper communication, staying composed under pressure, and constantly learning because of the many, many advancements. Obviously, you're never done learning, and I really respect that. And these valuable experiences, they not only strengthen my desire for cardiology, but they also solidify my desire to work in medicine. And I hope to be a physician that works with dedication, curiosity, and heart, just as I've learned from this mentorship experience. And I want to thank my mentors, my colleagues, and the cardiac cath lab team who taught me so much. I want to thank Ms. McKeever, Ms. Orr, and Mr. Majorni for giving me this opportunity, and I want to thank my parents for letting me take the card. And I want to thank everyone from the cath lab team, Patty, Joe, John, Phil, Kira, Eddie, Peggy, Zumi, Erica. If I forgot anyone, I'm so sorry. But they really taught me a lot, and I'm really, really grateful for this experience. I want to talk about one last thing. It was like a very minor procedure. I learned that outside of operating in the very, very big cath lab room, there was a lot of bedside procedures done. There was one called a TEE, transesophageal electrocardiogram. So basically, the patient is put under very, very heavy sedation, but not out completely, just very heavy general sedation. And there's this giant scope that goes down their throat, all the way down their esophagus, and it goes behind their heart. And what they're doing is they're checking for a certain condition called a PFO, pain form and ovale. When we're all babies, when we're all in utero, you have this ovale, this heart, hole in your heart that's connected to your mother's heart, and that's where you get a lot of your oxygen from. And as you get later on in utero, when you're very close to being delivered, usually that hole closes up by then and you're delivered without any defects. However, for a small percentage of the population who still have that open, it can cause a problem because that hole can actually lead to oxygen going instead to your heart, it go up to your brain and can cause a stroke. So that's why I was also really it was really nice to see how cardiology was related to so many other different fields. So I really liked learning about the TE as well. And yeah, I really like this experience. Does anyone have any questions? Alicia?
So I know you talked a lot about being in the cath lab, but did you get to interact with any of the patients?
Yeah, so I did spend most of my time in the cath lab, but when I did go to see patients, I got to learn about conditions, their history, and their overall journey as to what they've been through. There was this one patient that I still remember very well. Most of the patients, like Ryan said, they were in their 50s all the way up to their 80s. There was this one patient, he's 21. He had a lot of familial hyperlipidemia, so which is high cholesterol genetically from his parents. And he had high blood pressure. He had a lot of conditions that we see in usually older patients. And he had sleep apnea as well. And he said he drinks a lot. Somehow that was related, but I'm not sure how. But the doctor kind of gave him these medications to kind of help thin his blood. They gave him Eliquis, which is a very strong blood thinner, which is kind of like on the same level as heparin. And it was just like seeing all these different patients, all these different conditions. I really got to see how the doctors talk with them, and their patient-led care was amazing to see. Any other questions? Ms. McKeever?
I kind of missed it. What was this condition? Impella, did you say?
Yeah, so the Impella it's not really a condition, it's more like a device. It's like a very big scale kind of stent, almost. It's kind of used to open multiple stents and multiple arteries at the same time. And there was a complication specifically in the right